Mind Deconstructed, Mental Health and Wellness with Dr. Kaz and George.
The statements of Dr. Kaz and George are not a substitute for medical care, and our opinions are our own. If you are experiencing a mental health emergency, please seek assistance from a professional in your area.
You can contact us via Twitter at Mind Deconstruct. I'm your host, George. With me is Dr. Kaz. Dr. Kaz Nelson is an American Board of Psychiatry and Neurology certified psychiatrist, licensed to practice medicine in the state of Minnesota, and an assistant professor in the Department of Psychiatry at the University of Minnesota Medical School. On today's episode, Healing After Trauma, PTSD Treatment. Dr. Kaz, last episode we talked about PTSD diagnosis. Today it looks like we're going to delve a little bit into the treatment side.
Yeah, this will be one of the first episodes where we're getting more in depth into treatment, other than the show that we did more generally on psychotherapy.
I also would like to give a quick shout out to episode 2, our psychotherapy episode. I thought that episode was very informative and a really good episode. I think people out there might be scared of that episode. They might be a little scared of the idea of therapy or what psychotherapy is. But that episode was really informative for me, and I think it could be also to our general audience, people that may have skipped that episode. Could maybe go back and give it a listen. I think it's a good episode.
Well, the word psycho is just a weird word in itself. And then when you put that with psychotherapy, there's just a bit of a mystification there that doesn't necessarily make you want to understand more. But I think if you get past that and take a little bit of time to understand the framework of therapy and how it works and how it leads to healing in the brain, it does help understand what is going on in the brain. And I think this episode will highlight that a bit more.
Starting with some hot topics in mental health, Dr. Kaz, what's going on in the world of psychiatry?
Yeah, well, particularly when it comes to PTSD treatment, there are some recent developments that are pretty interesting, George. Glad that you're an attorney and can bring your legal background into the discussion here, because a little bit of it has to do with national laws and even local policies. So the first development that is kind of interesting in this realm is the Food and Drug Administration, or the FDA. That's the large federal organization that approves medications for certain uses and is responsible for the safety of medications, recently gave the green light on studying a drug known as MDMA, or it's known on the street as ecstasy. It gave the green light to go ahead and do clinical trials to see if this substance could be helpful in treating PTSD, and that was last August when this happened. So over years, there's been a lot of advocacy from certain scientists and certain patient groups advocating for use of ecstasy and in therapeutic ways. And so ultimately, this will help us learn more if that is a pathway to recovery or not.
What are they hoping MDMA or ecstasy does for a person?
Well, there's this whole class of substances, hallucinogens, LSD from the 60s and 70s is another one. There's an anesthetic agent called ketamine. And generally, it's known that these substances impact the brain in different ways. I mean, that's why people have sort of been using them recreationally over time. But there's anecdotal reports or certain limited instances where people who were struggling with chronic distress or depression maybe used these substances and then felt quite a bit better, either for a short or a little bit longer period of time. And so it's led the field of researchers to say, gosh, could we harness this potential and use it to treat mental illness? And of course, that begs the question, well, did the person feel better because they were high for a little bit?
Felt really good.
It felt really good from doing a substance. And it's probably a little bit more nuanced than that. It's possible that some of these substances lead to certain windows of plasticity or flexibility in the brain or one's thinking patterns, and maybe that opens a window of opportunity to think differently or consider different ideas that were originally sort of closed off or sort of rigidly rejected. Well, that's the theory anyways, but that's yet to be borne out through research, and it's certainly not a recommended treatment at this point, but some early investigation of its potential is underway at this point.
And research is the way that psychiatrists, figure out what medications should be used for, and all doctors really. That's kind of the way it goes. Being the lawyer in the room, MDMA, along with a few other drugs that people have heard of, such as heroin and marijuana, are in a Schedule 1 class, which means that they have no therapeutic use, according to the federal government. So there's no reason, and it's impossible for a doctor to prescribe those drugs. And I know a lot of states have legalized marijuana, but that's currently in obvious conflict with federal law. And under the Obama administration, there was some loosening of those sort of enforcement actions. But I know that we're kind of a lot of states kind of feel up in the air about what's going to happen to marijuana. And I know Minnesota is among them because we have a legal marijuana program here also.
Yeah, in Minnesota, we have what's called by the state legislature a medicinal or medical marijuana program. And so the state came forward with a list of conditions like HIV or multiple sclerosis, which if a person is certified as having this condition by a physician, they may directly go to a state dispensary and prove that they have that condition and work with a state pharmacist to access liquid cannabis as a therapeutic agent in this model. And interestingly, for a while this program had been underway, there were no mental health conditions on that list. But last August, post-traumatic stress disorder was added to that list of conditions that in Minnesota, if certified, opens the door to accessing marijuana. And this was extremely controversial. There's a lot of physicians who were not happy about PTSD being added to this list, in a sense that perhaps the state moved ahead of science in determining this access for people with PTSD. But then, of course, there's multiple proponents of taking this step. And so it's a very hot topic and controversy in the field at the moment.
And my understanding is that a liquid form is not the preferred way for most recreational users to consume marijuana. I mean, I'm sure you don't have any opinion on that, but I know in some places, historically in California, you get your, you go in, you tell the doctor you have migraines, and you get your marijuana card, and you get to go buy and smoke marijuana whenever you want.
Yeah, our program was set up differently, I think, to stop short of that kind of model. And so they limited to just these liquid forms. And by doing that, I think they are thinking that really only people who, quote unquote, truly need it have access to it under this program.
The other interesting part about the program is health insurance does not cover marijuana.
Correct.
And it's expensive.
Yeah.
I mean, medical marijuana is expensive. These firms invested millions of dollars to develop these liquids, and they are not cheap. So you could still buy marijuana illegally.
Probably for much more affordable rates, yes.
Much more affordable rates.
People who access these medical marijuana programs in Minnesota are probably suffering with severe symptoms and feel that this has been a life-changing or miracle drug for them. And I'm not going to stand there and tell them that it's not been meaningful in their recovery, particularly for disorders that I'm not directly managing, like I mentioned HIV or cancer or something like that. But I think the disappointing aspect for PTSD is that we do have treatments that can substantially improve symptoms, and we'd love to be able to have a chance to treat people and offer them cutting-edge treatments in a way that provides meaningful recovery where they're not feeling like they need to access marijuana to manage the symptoms.
Are you aware of any studies testing medical marijuana in relation to PTSD?
I'm sure they exist to a limited degree and were probably cited as the state took this step, but I can guarantee that they are nowhere near sufficient to be able to recommend this as a course of treatment.
Well, what options are there for treatment for PTSD then?
Great segue, George. Well, the thing that I want to mention prior to talking about treatment, because I think this is a really important point, and I kind of see this every day. And if somebody is having extreme anxiety or that kind of post-traumatic stress response that I mentioned in last episode, that hypervigilance, that startle response, just completely sort of living on pins and needles, it's not post-traumatic stress disorder if somebody is currently in a harmful or dangerous environment. Then it might be actually appropriate stress or anxiety response to danger. So sometimes I'll be meeting with someone and they say, yeah, I really need treatment for my anxiety and my PTSD because I just live in fear every day. And you learn a little bit more and, well, their husband beats them up every day or something like that. And I don't mean to laugh, but I say, gosh, there's no treatment in the world that will take anxiety away, nor should it, for somebody who's currently in a dangerous environment. And the treatment or the intervention for that is accessing safety and security, step one. And then you can kind of assess if there are symptoms that are targetable through psychiatric treatment, which there probably are. But the point of psychiatric treatment is to treat symptoms that are out of proportion to what somebody's enduring or representing dysfunctional mental health response. We are not there to take the sting out of symptoms or experiences that are meant to protect you from a dangerous experience that's going on in that moment.
As a psychiatrist then, for someone who does come in with diagnosable PTSD, what steps are you going to take to determine how to treat them?
First thing I do is determine what criteria are met for other diagnoses. If somebody also meets criteria for something like schizophrenia or bipolar disorder or major depression, that's going to cause me to tailor my treatment plan. If somebody has severe suicide thoughts or self-injury or another set of symptoms which are called dissociation, which is where the brain basically loses awareness for periods of time in order to cope with severe danger. All of those things need to be identified if they're possibly present. And so a good evaluation will include checking for all of those things in order to come up with a treatment plan, because the course of treatment might be a little bit different depending on if there's other disorders present or other at-risk behaviors. So that's step number one.
So then you have the person in your office. They just have PTSD.
Mm-hmm.
Let's say it's a veteran who has some past trauma and is experiencing some of the symptoms, enough of the symptoms that we talked about in our last episode to be diagnosed with PTSD.
Mm-hmm.
Walk us through it.
Yeah. So comprehensive treatment plan for PTSD may include medications, but it should include psychotherapy treatments. And I'll go into a little bit more detail there because there are some good specific psychotherapeutic treatments that help with PTSD. But from a medication standpoint, there are actually 2 medications that are approved based on the research that's been done to show that there's significant improvement. Those 2 medications are called citalopram or sertraline. They're in a class of medications called selective serotonin reuptake inhibitors, a group of medications that were developed to actually treat depression and anxiety, but they have been shown to help with PTSD.
Those selective serotonin reuptake inhibitors were first, like you said, were first developed to treat depression. But these 2, I've never heard of these 2 as depression treatments. Are these also drugs that may be used for someone with depression?
Yep, these are first line. And the weird thing about medications is they always have a generic name and then brand names associated with them. And many times people are more familiar with the brand names due to advertising or things like that. But in medicine, we're trying to get into a mode where we are usually using the generic names of medications. So should I say the brand names?
Lay it on us. What's the brand name?
I don't want to act like I'm, advertising for a pharmaceutical company, but these are FDA approved. So The usual brand name for citalopram is Celexa, and the usual brand name for sertraline is Zoloft.
Oh, okay. Definitely heard of both of those.
Mm-hmm.
Would both of those be prescribed, or just pick one, or how do you choose?
Usually one, and it's common practice to sort of start at a low dose and then move up to a target dose over time. Sometimes people can have stomach ache or nausea or diarrhea, and then there's actually some sexual side effects that can go along with this class of medication that people don't tend to like if they're part of the proportion of patients who have that problem. So,
what is the sexual problem that someone may experience?
You can have sexual problems in any phase of the sexual response cycle. So sometimes you can have problems with libido or actual sex drive. Sometimes men will have problems, their capacity to obtain an erection. And then sometimes it just gets in the way of orgasm.
Okay.
And prevents that.
All things that people could find troubling.
Yeah. And there's a small number of people who say, I don't care about that. I'd rather move ahead with this treatment because I feel better. But I would say most people want to feel like they have healthy range of sexual functioning.
So then you've got the person on medication now, and you're increasing their dosage to a level where they're experiencing a benefit from it.
Yeah, and we typically quote, some people can notice benefit right away to some degree, but it usually takes around 4 to 6 weeks to notice the full benefit of that dose. And that's because this is not a medication that's a quote-unquote happy pill. It's not like you take it and you feel better that day. That's not at all how it works. That being said, we don't know exactly how it works, but it subtly changes neurotransmitter signaling in the brain. That sort of takes time for these signaling pathways between neurons to change and adapt to the medication being in the system. And so it's a little bit of a subtle process that comes over time, but compared to placebo or a sugar pill, it was associated with increased response in symptoms with, measures of primary symptoms of PTSD.
Now, this is kind of the first time we've gotten pretty in-depth with medications, and it's an interesting subject for me. And anecdotally, with the selective serotonin reuptake inhibitors, or when you're treating depression, it seems like what I've seen non-medically is patients sometimes get to a point where they're like, oh, I've been feeling really good for a period of time. I'm going to stop taking my medication now.
Mm-hmm. Depending on the person, that might be the right course of action, but it's always good to work with a provider on what's the plan then, if symptoms recur, what's going to be the plan, or if somebody has had multiple episodes of depression or anxiety, it may be better to go on what would be considered a maintenance or preventative long-term use of the medication. And so everybody's a little bit different, but I would say it's important to make those kinds of decisions about stopping or going back on medications with somebody who's really trained to manage that carefully.
So we've got him on medication, following his doctor's advice.
Yep. And it's very difficult for people to, the expectations of medication can be very disappointing if you've been on citalopram a couple weeks and you still feel horrible. You think, what's it doing? Or, even though it was better than sugar pill, it's still not going to probably take away all the symptoms or make somebody feel 100% completely better. And that can be frustrating because there's always hope that the medications are going to really make symptoms go away. And so there is a tendency for people to advocate for, or sometimes physicians even say, well, in the short term, let's prescribe other classes of medications that have more immediate relief for anxiety, are more sedating, or
give them a few Xanax, or what?
Yeah, there's alprazolam, diazepam, lorazepam, medications in the class, what we would call benzodiazepines, that really are effective in treating anxiety in the same way. They're a little bit chemically similar to alcohol. So in the same way people take a shot of whiskey and gosh, anxiety feels a little bit better. Yeah, of course it does. And these pills act a little bit similar to that. And so it's very tempting to want to go kind of down that course because of the degree to which people are suffering. But the VA has come out pretty strongly about this and gathering data and saying, of course that's tempting, but when you when you use that as a sort of a long-term treatment or beyond a couple weeks, it can really actually get in the way of PTSD recovery and treatment. And so they actually recommend not pursuing that pathway at all, even though it's sort of tempting.
And that class of drug is prone to some level of abuse, isn't it?
Well,
or dependence, I should say.
Yeah, dependency. And people say, well, I'm not a drug addict. I'm not going to have problems with this. But the point is, it is a class of medication that causes dependency and tolerance. And that means that your body kind of gets used to it over a short period of time. So if you take the medication and then your body gets used to it, then you say, gosh, the symptoms came back. I need double the dose or triple the dose or quadruple the dose now. And you kind of get down this spiral where your body's getting used to it. And then sometimes even if you were to stop it, you can actually have withdrawal symptoms similar to alcohol. And so it is a bit of a tricky road to go down. And there are some psychiatrists and physicians who advocate for just not going down that road and using evidence-based therapies that are actually shown to work better over time rather than this route, which could potentially complicate treatment or make things worse over time, even though it seems to benefit in the short term.
Short term, yeah. So should this person start their therapeutic treatment right away or wait until the medications kind of take effect after a couple of weeks?
I think the sooner one starts good, competent psychotherapy, the better if somebody's struggling with PTSD. It really is the gold standard for treatment. The main type of psychotherapy that has the largest amount of testing to support its use in PTSD is cognitive behavioral therapy. We talked about that more in detail in our second episode on therapy. But CBT is a way to treat the symptoms, and I'll tell you a little bit about how it works. So first of all, what is PTSD and how does it disrupt the brain and the brain functioning? Well, the brain wants to prevent trauma in the future, and so it goes on hyperdrive and causes this nervousness and scanning for danger. And part of what it does is actually take traumatic memories and sort of just throw them in front of your screen and throw them in front of your awareness in kind of a willy-nilly way to try to prevent future danger. And what CBT does to treat that is actually go through the traumatic experience while you're also practicing relaxation and calming techniques so that the memories can sort of be put away in the memory filing cabinet, where it's not like you erase the memory, but it's sort of put away where if you want to access the memory, you can open the drawer and get it. Just like if I were to say, who was your third grade teacher? You might say, oh, give me a minute. And you could think and recall that teacher, but it's not like you're thinking of your third grade teacher every day, hopefully, in an intrusive way. But you might have PTSD if that's the case. But what this CBT does, or the specific name for this trauma-focused form of CBT is prolonged exposure, is you go through a story of the trauma while you're in a relaxed state in order to put those memories away in the file cabinet where they belong and not just intruding all the time every time you are faced with a prompting event.
It sounds like that could be pretty difficult for people to talk about their trauma.
Yes, and you have to obviously know what you're getting into. A good CBT therapist will explain the therapy in detail. So nobody would ever just spring this on anybody. It has to be a consent process to doing that. But what we try to reassure people is that one of the reasons that's very painful to talk about trauma is because of the body's response to it is so painful and so aversive. But what we do is work with somebody to go into a state of relaxation and talk about the trauma in a way that decouples the trauma thoughts to that uncomfortable sensation and separates it a little bit. And so it actually is quite healing. But yes, part of this is going into quite a lot of detail about the major traumas one that has experienced. They'll even talk about what you see, hear, taste, feel, as many details as possible so that when you think of those memories in the future, you're not going to have that panic associated with it. in addition to prolonged exposure therapy or CBT, they also have protocols to help with nightmares. So one of the problems is people with PTSD have this trauma response even when they sleep, and their adrenal glands are releasing stress hormones, and all of these hormones and different things are going to the brain, and your body and brain are panicking while you're sleeping and generating nightmare content. And so there are ways to actually talk about recurring nightmares and change the ending of the nightmare during the day and practice that, so that at night, when you start to have that typical dream, you can have actually more control over the dream at night when you sleep and change the ending so it's not quite so panic-inducing and won't wake you up in a cold sweat. And that's pretty innovative treatment that a lot of people have benefited from.
That's interesting. That almost sounds old school psychiatrist sort of thing. Maybe it's new school, but like talking about dreams and like.
Well, nightmares are one of the primary symptoms that people will come in with, because when that sleep is disrupted from waking up in a cold sweat over and over again, it is tremendously painful to live that way and have that, impact on your life. And so that's sometimes people's main problem that they come in with is nightmares. And I'm really happy that this protocol, which is effective, was developed to give people more control to manage that.
Yeah. Well, we're running low on time. Any other elements of PTSD treatment that you want to inform our audience about?
Yes, there is a treatment, eye movement desensitization reprocessing, or EMDR, which is a newer treatment and also involves talking about trauma, but has the person look at some lights that flash on one side or the other, or touch their body on opposite sides, tap their knees at different ways. And the theory behind that is that exercises both sides of the brain while you go through the trauma narrative. And the people who developed it thought that offered some advantage over just what the CBT therapists do. And
you don't sound convinced.
Well, it's not really been compared head to head in a way that we could satisfactorily say that. But the bilateral stimulation obviously isn't harmful. Looking at lights or tapping the knee isn't harmful. And so it's something that might be helpful. Supportive psychotherapy or psychodynamic psychotherapy are also shown to be helpful for PTSD, but maybe in a less specific way. And then my final point that I would want everyone to know about is that for cases of PTSD where there was early trauma or recurrent trauma, chronic trauma, maybe people that were in a neglectful situation or, in different foster care situations or hurt, at an early phase. In Georgian child protection, you've probably seen this over and over again. That kind of trauma, you can't just sort of do a course of CBT or EMDR to help with it. You kind of need to start with therapies that focus more on just being able to calm down, something like dialectical behavior therapy, and maybe do that as the first phase. And then after you have some basic self-management symptoms and a sense of safety and suicide's off the table, then that might be a point in time where somebody could move on to one of the more what we would call trauma-focused approaches.
That makes sense.
Yep. It's a really hard thing to see when somebody kind of jumps right into those therapies talking about the trauma and they just aren't, it's not a safe thing for them to do. And then sometimes they'll end up hospitalized or with a suicide attempt. And, we want to avoid something like that.
Yeah, they're just not ready.
Yep. Not yet.
Thank you for joining us today. This podcast was produced by Kaz and George. Music by Paul.
He's the best.
Contact us and send us your questions on Twitter at MindDeconstruct.